Good evening, and welcome to Health Plus Weekly. I am Dr. John Podkowa. I'm joined by our co-host, nurse practitioner Hannah Raymond, and we are excited to welcome to the studio tonight Dr. Robert Sandfort, the medical director of our new wound center at St. Luke's Hospital. Bob, thank you very much for coming.
Oh, fine.
We have a great show this evening. We are going to be talking about Southcoast's newest wound center located right in St. Luke's Hospital in New Bedford, and also about the wound care services in general at Southcoast. There are two main locations in Fall River and also now at St. Luke's. And we'll be fielding questions, so please feel free to write in if you have questions regarding wounds or family members who have wounds and how they've been handled or how to kind of access our wound center. And also, if you have general medical questions, Hannah and I are happy to answer those as well.
If you want to join in too,
Sure.
Try your hand.
We'll try to kind of wait till the end of the show to answer the general medical questions. So if we don't answer them right away, please be patient with us, but we will. So please, write in via Facebook, questions, and also we'd love to hear where people are listening from and kind of what your summer plans are this summer and who's watching, so we can kind of just say hi. We appreciate all the engagement in the show and the turn-in. Last week's show was great, and we appreciate it. Bob, thank you very much for coming on.
Oh, great. I'm glad to be here.
One of the first things we like to, just introducing our guests, is a bit of background in terms of, how you found your way into medicine and what then kind of how you found your way into wound care and then also Southcoast.
Well, I was always science-oriented, so I went the science courses in college and then medical school, and so I was also always mechanically oriented, and so surgery was a natural fit for me. So I went to the medical school and then surgical residency. I did my residencies down in Philadelphia, and then I
Where about in Philadelphia?
Temple.
Oh, that's where I trained.
Is that right?
Yeah, I didn't realize that. Yeah, absolutely. I trained at Temple. Yep.
And so then from Temple, I did a colorectal fellowship in Allentown, and came here in 1987. I've been a colorectal surgeon up until now, and the last 4 years I've been doing some wound care at Charlton. And recently started getting more interested in it, and took a board exam, took a bunch of courses, and was offered the position of the director of New Bedford. And I said, oh, that's a good way to slow down possibly and not have to take call.
There you go.
Surgery. And so so it's been good. I really enjoy it. It's challenging, but also satisfying.
I bet.
And so this is your second week on the job, we heard.
Second week in New Bedford.
Yeah.
I've been at Charlton 1 day a week for 4 years, and a little over 4 years. And so I got a taste of it there, and I like it. So.
Where are you from originally? Were you from New England?
Originally Pennsylvania.
You were?
Yeah.
Okay.
So that's how I kind of found my way to Temple and Philadelphia.
And then was it the job that brought you to New England?
Yep. There was a group of surgeons out of the Truesdale Clinic who were really good surgeons, and so after interviewing around, I said, "Geez, this is a nice place. It's also a nice place to live." So my wife and I, decided to say, "This is the place for us." You got Boston, you got this, you got the coast, and so we really kind of enjoy it. And we've been here for 30-some years. So
I'm from New Jersey, trained in Philadelphia, Temple as well, lived there. I was a National Health Corps scholar, and that's what brought my family and I up to in 2009. Yeah. And I agree with you. First of all, the medical community is great around here. I mean, so many great specialists and for a community medical center. And it's a really nice corner of the universe, as one of my patients said when I first got here, in terms of being able to live here. And no traffic, so quiet, and it's just awesome.
I often joke with, not growing up in the area, I often joke with the patients that I'll keep the secret about the South Coast.
We used to
area.
say, keep it secret, and I'm going up to New England to this area, but don't tell anybody.
It's near the Cape.
Yeah. Hannah grew up in some Rentham area, and so she still comes pretty far way down. So it's definitely we appreciate it.
So it's a treat,
This is a beautiful area. So.
First I want to say thank you. I mean, you have, and the Wound Care Center has taken care of a number of my patients, and also I think a number of my colleagues' patients, and it's such a great resource to have for many of the patients I've sent are diabetic patients, which we'll talk about, but who have helped with these wounds, and it's unbelievable, the services. And it's funny, I'm sure you recognize this, though, but people, who, I think, from both Fall River and New Bedford like to stay within Fall River and New Bedford. So often the greatest challenge I had in terms of kind of convincing someone to go to the wound care center was that they had to go to Fall River a lot of the times. And so now that it's in New Bedford, I mean, that threshold for getting them there will be even lower, so it's been really great.
Yeah, because, I think probably half my patients were from New Bedford when I was in Fall River, and so, we looked into it, and the hospital looked into it, and said, geez, we could capture some patients that are going elsewhere or not going elsewhere, and that's what we found. Is like a lot of people are just hiding their wounds or not taking care of them very well, and so now they don't have to drive that extra 12 miles or so. So we're seeing people, and I'm actually having some of the people from Fall River who I take care of in Fall River are transferring their care over here. We have a number of patients already doing that. And so it's a good resource for this community.
Could you describe a little bit? So the wound care center at St. Luke's is relatively new in terms of the physical space. Could you describe
about
a little bit?
2.5 weeks.
About 2.5 weeks. So is it a freestanding building? Is it located in the hospital?
Oh no, it's very convenient for patients. It's actually more convenient than the Charlton location because it's right outside the emergency room.
Little competition, right?
Yes, and so it's very easy in, very easy out for access. So it's right next to the emergency room, and it's a brand new space, nice, very nicely done, even a little nicer than the Charlton spot, I would say. But,
and who's your team there? Who do you work with? Like, how does the process work?
Well, Sue Aguiar is the nurse who runs the clinic. We have a number of nurses, both coming from the Charlton site on a daily basis, but also training some new nurses to be full-time. Sue's been at the clinic at Charlton since inception. She was there for eight or so years. And of course, we have a new director, Mary.
So just by saying that, because I've worked with Mara before in the past, I have no doubt the success of your wound care center is going to be
she's an absolute go-getter.
Exponential, yes.
And
we'll try to get her on camera later tonight. She's here with us.
She's been great, and the reception lady is doing an amazing job because this is a very difficult job. She's Lisa, she has to field calls from offices and take care of the patients and bring them in. So I was wondering how she was going to do, but she's really fitting in very well.
And you guys are open Monday through Friday?
Right now we're open Monday, Tuesday, and Wednesday with plans to be open on Thursday and Friday. Okay. With as the population and the number of patients we need to see expands. So yeah, I'm doing 2 days. Dr. Erdley, one of my partners, is doing Mondays. Planning on having a nurse practitioner dedicated to the wound clinic on Fridays. And Thursday's still up in the air whether another physician or I'm going to take the Thursday. We'll see. Okay. How that goes. But yeah, the plan is Monday through Friday. Great.
So we have a question kind of getting into it. I know we've talked about kind of the logistics of the new wound care center. We have a question from Carol asking, what kind of wounds do you take care of? And this could I'm sure be a long answer, but that's great. Yeah. We can kind of get into it a little bit here.
We do any wounds. Most of the wounds are related to medical problems such as diabetes, but any kind of wounds that have been like surgical wounds, traumatic wounds that people have been seen in the ER that are not healing very well, wounds from people who are neuropathic, who can't feel their extremities and they develop ulcers.
Do you work with burn patients?
Burns, I saw a burn wound today,
Okay.
referred from the emergency room, and so, yes, we don't do major burns. Most of those are done, they actually don't even stay at the hospital.
Yeah,
Like, more than like a 20% burn, or depending on the degree, is sent to a burn center. But minor burns that need follow-up and wound care, changing of dressings, or various different salves that we have for burns, yes, we do take care of them as well. So.
How do patients typically find their way to you? Do they get referred in through
Most
their
of the-
doctors, or can patients self-refer to themselves?
Both.
Okay.
Yes, we've had a few self-referrals, but a lot of them at this stage are from the family physicians or the emergency room. And also some surgeons. We've had probably a fourth or third of our patients so far referred from other surgeons, just since we've been open from like the 2.5 weeks. But most of them are referred from other physicians and family practitioners, et cetera.
So one of the common themes that we always touch on, being primary care focused ourselves, is prevention, or who's at risk for wounds. And you touched on a little bit about what types of wounds you see as to kind of the cause of the wounds. So who is at risk for developing a wound?
Well, the classic and the patients that are really in danger of wounds and really need to be vigilant are diabetics.
Okay. And why is that? How does that come to be?
Well, diabetics, long-standing diabetics, have problems feeling their extremities.
That was the neuropathy that you
They get
talked about.
neuropathy, and consequently, the classic is somebody gets a new pair of shoes, or all of a sudden walk. I had one diabetic walk on the beach without shoes and burn their feet because they can't feel. And the repetitive motion of a bad shoe fit, or not taking care of their nails, they really should see podiatrists frequently to get nail care, can end up with a wound that can end up with a major infection.
Okay.
And
So just simply because they may not even know it's there.
they just don't feel
Right.
it.
Yeah, I think I always talk about diabetic, we don't appreciate just the subtle nuances of moving and with the feedback that we get. So if something's bothering you, that they kind of gradually lose.
Yeah. So even when we get a wound healed, part of our thing is to make sure they do self-examinations, daily, the proper fit of their shoes. We have referrals where we send people to get shoes made for them, make sure they wear proper socks and so forth. And so, yeah, that's part of the whole information and education that we do with patients.
And I guess it's the same thing in terms of people who you said are like, whether they've had like a spinal cord injury, or maybe have multiple sclerosis, or other kind of neurologic diseases that are wheelchair bound, bed bound. That they same thing. They just were meant to move in a way. If you're not moving regularly.
Yeah, that's another probably a lot. Probably 10 to 20% are spinal cord injury, paraplegic patients with pressure wounds. And part of that is vigilance, moving the patient, even special wheelchairs for people, special seats for the wheelchairs. And then when they do get it, we have to use special either vac dressings or other, right?
That's okay. If you have to get it, we understand. We can.
No, that's all right. At any rate, yeah, and part of that is also teaching the facilities that they come from, because frequently they come from rehab and this and that, and if they end up developing a wound there, part of it is our team calling them and making orders for they have to be moved every hour or 2 hours or something like that.
Do your teams go into the hospital and work with inpatients at all? How?
The wound care facility does not, but there is a wound care nurse in the hospital.
Yep.
There are a number of them at Charlton, and also Lisa Sears at St. Luke's. Very good nurse. She's had a lot of experience. And so she will refer the patients, and she does the wound care in the hospital. I did a little wound care in the hospital at Charlton, but not a lot, but we will direct them if asked to see what other therapies they need, or if they need to be taken to the operating room for cleaning up the wound, something like that.
And you guys have a great kind of relationship to transitioning them to outpatient if need be.
Yeah.
Oh,
Lisa's been good, so.
Yeah.
So, so diabetics are at higher risk of developing wounds for all the reasons that we spoke about, and that's certainly something that we address in primary care in terms of prevention, asking people to go to the podiatrist, check their feet every day,
Yep.
all those good things. What about people with vascular disease? So either venous or arterial disease, which we have spoken about on the show with Dr. Pinn several weeks ago. They're also at risk.
Yeah, I mean, the venous ulcer disease is probably our most common wound.
And could you describe that a little bit? What's the mechanism behind that?
So basically you have blood vessels that take blood down to your extremity, your hand or your foot. And then you have vessels that take blood back to the heart. And one thing that happens with veins in the legs is over time, there's a valve in the veins that gets worn out. The blood can go up and the valve shuts like a trap door. And over time, especially people who stand a lot or keep their legs down a lot, the valve gets worn out and the blood can then get, it goes up,
wins.
but gravity goes back and they get swelling of their legs. And what happens then is, if it gets really bad, then any nick or cut in the leg can then expand because the blood the oxygen in the blood can't get to that area because there's too much swelling of the leg and they develop a wound, which is sometimes a bugger to heal, but mainly it's putting compression stockings on people, using various wound salves and creams that we can get this healed. But the main thing then would be to, after we heal it, is wearing compression hose.
To prevent it from happening again.
If possible, not standing all day. I had a lady who was a greeter in Walmart, and we really didn't heal the wound very well until she quit her job.
Oh, no.
She retired.
Yeah.
And so once she quit, we didn't see her anymore. She healed her wounds.
Right.
The other vascular issue that you mentioned is arterial disease. And this is a natural development with time of people's arteries getting clogged, especially people who smoke. And over time, it's sort of like when the arteries of the heart get clogged, you get a heart attack because the blood can't get to the heart.
Right.
The same thing can happen to your feet and lower legs because the arteries get clogged and the blood can't get down there to heal the wounds. And similarly, any nick or cut or cat scratch or whatever can then turn into a huge wound that's difficult to heal. Now, we can, as you mentioned, Dr. Pinn, we work with the vascular surgeons and we can test people in the clinic. We can say, oh, geez, they're really not getting enough blood flow. So besides taking care of the wound, we work hand in hand with the vascular surgeons, refer to the vascular surgeons so they can perform. Now vascular surgery is so much more advanced than when I was in training. But back then we had to make big incisions and so forth. Now they can do things through little cuts that are unbelievable. And once you get blood flow down to the wound, it's a lot easier to heal. And so, it's so those two things. The vascular, a lot of the time we get them healed a little quicker. The venous, it takes a little time, but once we get the people off their feet and compression, we can get them healed. And we had actually 2 healed wounds already from venous disease in our clinic today.
And you also work with, one of the great things that we love, I think, working with Southcoast is because it takes a team to really effectively care for people, especially people who have kind of complex problems going on. So we love having like you, Dr. Pinn, and also infectious disease you work with a lot, like our colleague, Dr. Brian Stilley, who's been on the show a couple times in terms of, if there's antibiotics are necessary. Do you work with, who else kind of from a, kind of collaboration physician standpoint do you guys frequently work with?
Well, we do. I've already worked with Dr. Seeley twice on 2 patients, and I've only been here a couple of weeks. So there's Dr. Alonso, who's infectious disease. There's a new infectious disease, Dr. Gorski, I think it is, at
Dworsky, right?
Dworsky,
right?
yes.
Dworsky, yep.
I was just talking with Dr. Appleman at Charlton yesterday, as a matter of fact. And he's a relatively new resource. And so infectious disease, we use them all the time. I would say probably 20% of our patients need them for various infections, whether it just be a cellulitis or chronic cellulitis. But most of the time, it's when the wound gets so deep that it infects the bone. And that's when we start reaching out to our infectious disease colleagues for guidance about how long, what type of antibiotic needs to be used. And that in conjunction with the therapy that we have at Charlton available, Hyperbaric, it's just amazing what we can do with that kind of resource.
In terms of for people watching tonight and why you worry about wounds, obviously from the pain or just the discomfort from them, but if they're not addressed, then they can lead to one, serious kind of significant infections that can affect the bone, and then that could travel to the heart and a whole host of other illness. But also, in the patients who have trouble with their blood vessels and also diabetics, right, unfortunately it can lead to a lot of amputations, and which can affect your quality of life, your job, your employment. And if caught early, though, I mean, that's part of what the great success of this is, that we prevent amputations, right, by taking care of this.
And that's what I mentioned, like when we were opening this wound clinic, we had a little thing. We try and get the people back to their life, all right? Because they're not, when they have this wound, it disrupts their entire life. And if they have an infection, like, today I had a landscaper, okay? And he has to, obviously, he's got to walk around and do his landscaping. So we're going to try and get this guy, well, first of all, we've got to limit what he does, but once our goal is to get him back to the job because he owns the company. And so he can't, take time out very far. So we're going to get him shoes. So what we want to do is get people back to their quality of life. And obviously if they have an amputation, this is going to markedly change their lifestyle. And so yes, the main deal is for limb salvage or leg and limb salvage so that they can get back to their normal activities.
Yeah.
That's perfect. We had a question from Mari asking, what are the risks, if any, when a wound goes untreated? So, again, just preventing a worse infection or in preserving the limb. So, at home, so say if somebody cut themselves or has, an abrasion as a diabetic and has a small ulceration on their foot, when would, what should they do at home, if anything, first, and when should they be either, coming to see us in the primary care field to take a look at it and maybe refer to you, or, when should people worry about a wound?
I think any lower extremity wound in a diabetic ought to be checked out.
Immediately?
Yeah.
So no home?
Primary care, they can clean it with some alcohol or whatever they have but within the next 24 to 48 hours, they should at least have somebody check it out. Because infections in diabetics can really progress rapidly. Okay, so you want to get that checked out right away, and if it's okay, it's okay. But if it's not, then you can jump on it right away before it becomes, an infected bone or, something that needs major surgery or drainage in an operating room. So I think if there's any question at all when they, whether they cut their toenails is classic. They cut their toenails, they make a wound, and they go, it's okay. They put a little, iodine or mercurochrome or whatever on it, and they think it's okay. But then the next day or so, that can blossom into something that's really bad. So I think they ought to be checked out, either nurse practitioner, anybody who can actually, has a different set of eyes, trained eyes.
And can also counsel on some of the other things too. So it may not be an issue at that moment, but what are some other things that if someone was sent home with kind of a watchful waiting, idea to look for in terms of coming back for care?
Well, obviously some swelling, redness, drainage. all those things, you know, we call them sausage toes because all of a sudden their toe is looking, you know, bigger and it kind of often, so people don't really see that very well, especially diabetics. They don't have their eyesight frequently is not very good. So I think that if there's any question at all, they really ought to get it checked out, even if they have to go to the emergency room, because if they see the emergency room and it's slightly infected, if they can prevent an infection progressing, even if they don't have to go into the hospital, it's much better to catch it early. You know, Dr. Monchak has time is tissue.
Yeah.
And so
for so many body parts too.
You know, in terms of what you mentioned too about homes, we try to just impress upon people, you know, just the importance of just cleaning the wound out with soap and water. I mean, people don't know, but that's like people underestimate the effectiveness of just really washing it, soap and water, cleaning it. I wanted to ask you, I see a lot, and you know, people love hydrogen peroxide. You know, if you see this, it's really interesting in terms of like put hydrogen peroxide on it. In terms of is that good or bad for wounds long term? You know,
well, long term it's a no-no.
It is. I mean, it is, right? I mean,
they don't even keep hydrogen peroxide in the wound clinic because occasionally they'll say, "Go get me some hydrogen peroxide," and I'm like, "Oh my God!" And wound nurses are like, you know, freaking out. But yeah, long term for sure, it actually retards wound healing. And so it's not a good idea. Maybe for, you know, one little dose or something if you need to do a cut or a burn or something like that.
Do you have patients say the same thing to you? It's real. I mean, isn't it interesting? I feel like
try
I've been putting hydrogen peroxide on it. Don't worry, everything, and I'm like, okay.
No, it's not a good idea.
No, okay. I want to make sure.
So we did have a question about some of the treatment options. So, you know, we have a wound. We determine that we need to send them to you at the wound care center. Kind of what's the progression of treatments? Yeah, where's the magic happen?
How does it happen?
So the main best treatment is to clean the wound out. Okay. We call it a debridement. Okay, but surgical debridement, or you know, cleaning the wound out in the wound clinic, has been shown, if you do it on a weekly basis, is one of the major best things to get wounds healed.
Why? Like, what happens?
Because the tissue that's in these chronic wounds, a lot of it is dead tissue. Mm-hmm. And it's just a focus that bacteria can grow in. And if you leave it there, the bacteria will stop the wound from healing. Mm-hmm. So cleaning that out, re-energizing the wound, if you will, the tissues around the wound, re-energizing the wound to start healing, is one of the major things that we use to heal wounds. The other...
and you do those right? You're able to do that in the office? Yeah. It's not, they don't have to go to the hospital for that?
No, we do it right in the office. We have some anesthesia or numbing stuff we put on the wound. So it's not very painful. It is painful. We use other treatments. Mm-hmm. There are all kinds of treatments to take that necrotic or dead tissue out. There are ointments that can do it slowly.
It's just, there can be topical debridement as well.
Yes, topical debridement. If it's too painful for the patient, we can use other honey we have a honey ointment that debrides and cleans out. It's also antibacterial. Right. And we have another ointment that actually breaks up the tissue. Mm-hmm. And I had a lady today that, you know, I couldn't get it, she was so pain, all of a sudden the stuff fell out today. And now the wound can start healing from the edges that are nice and clean. And so, and then we have a lot of wounds, like you said, peroxide used to be an old one, iodine solutions, betadine used to be an old one. And we don't really use them anymore because those two, and that's when I was in training early in my career, when I was a resident and so forth, it was like, clean it out with peroxide, clean it out with, betadine. It's pretty much been proven that these two things are not very good. Maybe in the first, if somebody had a really bad infected wound for the first week, but after that it's not good. So there are a lot of different wound topical things, bandages, if we will, that have antibacterial properties, have absorptive properties if the wound is weeping a lot, or the opposite will give the wound hydration,
moisture,
some
okay.
moisture. If it's a dry wound, if it's a...
I was always fascinated by that, like the wet to dry dressing and the dry to
Yeah,
wet. If the
it's
wound
like-
is wet, you want to put, you know what I mean? It's interesting
Dry.
what you do to it
Yes.
to help. Yeah.
And so now, I mean, all the amount of products is just amazing. There are literally thousands of products out there that all different companies make, but some of them have even antibacterial things in it. And then the last group of things that we have are skin substitutes. And when we are having trouble with the wound goes more than 4 weeks, 6 weeks, and we're not really making progress, there are skin substitutes that are either from bovine, cow, or pig intestines that we put on wounds that stimulate the wound.
So it's not necessarily a surgical graft that goes in
No,
there,
no.
it just goes on top.
Yeah, and what that
Okay.
does, it has, it has the enzymes and coenzymes that help wounds heal from the edges. And say a wound after a while, a chronic wound will get stalled. It kind of perks it up and starts. It actually forms as a lot of these form as a lattice work or a framework, like you build a house that the skin can grow across.
Right.
We don't use them all the time because they're very expensive, but if the wound is stalled, we're not making progress, these are also things that we can use to stimulate a wound to grow and decrease the healing time.
Right, and I think that's important too, that wounds heal from, outside in and kind of down to up and like, filling
Yeah.
in, from the sides, which is, we have a question here from Carol about kind of an insect bite on a child swelling and is warm to the touch and stays red for a few days. Should bacitracin or any other antibacterial creams be sufficient? Any recommendation for that? Or anything that stays, an insect bite that stays red?
Depends on what kind of insect it is, okay? Because the thing about it is you really kind of have to be careful about, well, it's just a mosquito bite. Well, Benadryl ointment would be nice and stuff. But if it's a spider bite, and especially if you knew what kind of spider, it'd be nice. There's a couple of different spiders that can actually be serious enough to see somebody in the emergency room, only because they can cause dead tissue underneath the skin that you really can't see. So that's a kind of a question I can't really answer without seeing.
But generally, anything that stays red for several days.
Yeah, or it's
warm.
very painful.
Yeah.
If
Yeah.
it's red
Yeah,
and it's
very
very
painful.
painful, the person ought to actually be checked out either in the
That's a great
ER
point.
or-
Kind of
Yeah.
pain out of proportion
Pain.
is always a
Right.
bit of a concerning thing in a host of situations, but something with that. And certainly with redness of the skin, if because you worry about, kind of a severe, I guess,
Or
cellulitis
it's
under the skin, right?
it's getting an infection
Yep.
that needs to drain or have antibiotics. It's
What's the schedule like when people come in? Like how often do you do the debridement, the cutting down the wounds? Like, I guess it varies depending on the type of the wound and things like that. But
most of the wounds are weekly.
Okay.
Once we get them in, most of the time we see them weekly because a weekly check and cleaning out of the wound has been shown to actually decrease healing time. After a wound is stabilized, like I just put my first patient out at this clinic for 2 weeks because it's stabilized. I kind of know that I don't really need to do much next week. We can put them out for 2 weeks, sometimes 3, but the majority of wounds are seen weekly.
Okay.
So outside, what are some other treatments if those, the surgical or topical debridement doesn't work, the skin substitutes don't work? What are some other, we talked about compression for the venous ulcers. What are some other kind of modalities that you use?
Well, the star is the hyperbaric chamber, and the hyperbaric high oxygen chamber is like a I don't know if people remember 2001 Space Odyssey, where the sleeping chambers those people had. Well, it's sort of like that, only like more see-through. And a lot of people come and say, I want the hyperbaric. But unfortunately, hyperbaric is only for certain issues. But That's kind of like the superstar we have for a really bad non-healing wound, for for bone infections and for radiation injuries that haven't responded to normal therapies. And those are the kind of wounds that really kind of need it.
Okay.
This is our next step in those kind of, they have to be failed therapy for, like 30 to 60 days, and then we say, okay, let's talk about hyperbaric.
So if somebody comes to, it's not going to be hyperbaric on day one?
It wouldn't be hyperbaric
Yeah.
even in the situations where, we have a diabetic wound infection, or we have this, even a radiation injury. A lot of times we can get it healed without going into the hyperbaric chamber. But that's our ultimate fallback for these really chronic bad wounds that just won't heal over time.
So in the oxygen study, so what's the difference in level of oxygen between what we're breathing right now and in the chamber? It's for people.
Oh, it's 100% oxygen.
Pure oxygen.
It's pure oxygen, and what we're breathing now is about 20%.
Yeah.
And so
how long do they stay in there?
It's about an hour and a half. It's like 60 to 90 minutes.
How do they feel? Do they
They're
feel better?
watching TV. They feel like
They don't feel any difference in
No.
terms of. I feel like I would come out of there feeling like a million bucks.
Rejuvenated.
Yeah.
No, some superstars think it's helps
Yeah.
them.
Yeah, but it's not. They don't come out
No.
feeling.
It's relaxing. They can watch TV and read and so forth.
And what's happening? Like how?
Well, what happens is this, normally your blood vessels take blood down to wherever, and they release the oxygen. But the oxygen level can only get so high in the tissues, all right? No matter what, even if we breathe 100% oxygen, without the pressure, what happens is they're breathing 100% oxygen, but they're also in a pressure chamber, okay? And that pressure chamber pushes the oxygen into the tissues that would never get there.
So
If
that's
it
the
was
difference between just putting a 100%
Correct,
mask on.
because
rather
that's
than
still being
the actual-
brought by your blood
Gotcha.
vessels, okay?
So it's the actual pressure
The
that's
pressure is
Just driving it in.
driving the oxygen into the tissues, and you're reaching levels of oxygen that you would never be able to get to the tissues, that then triggers all the healing enzymes that normally would be triggered by oxygen blood flow, that are not getting there because there's no oxygen to that area. And you're triggering at least the healing process so that the wounds can start healing. That's that's the only thing that people will feel like. If you're in a pressurized chamber like an airplane, what they might feel is some changes in their ear. Even if you're like driving and you go up a mountain, you can feel the changes and you have to kind of clear your ears. That's basically what people would feel during the treatment. Otherwise, they're just laying and watching TV and stuff.
How quickly does it start to work in ballpark? And then how many times do they usually do it?
Well, they're usually about 40 treatments, and that's over a period of 4 to 6 weeks, depending on how they can tolerate treatments. And
40?
40.
Wow.
Yeah, 40 treatments for 4 weeks, 5 days a week is the usual treatment. And it can go up or down, sometimes more up than down, because some of the wounds we treat are pretty nasty. And so sometimes there's 50, sometimes there's 60 treatments. Another thing we do actually is people are going to have surgery. We'll treat them a little bit so that the oxygen gets into the tissue that's been that they're going to target for a surgery, and then they have their surgery, and then we bring them back, and then the oxygen's there for usually this is radiated treatment. These are people who have severe problems that are going to have surgery. So. Yeah, it does take about 40 to 60 treatments to make a difference.
And do you combine it as you're doing the other treatments as well?
Yeah, they're seen once a week in the wound clinic in a regular wound visit, and they continue with the 5 treatments a week otherwise.
Great.
Nutrition is a big part of wound healing as well. And do you help patients kind of with that? I know, certainly in primary care, we focus a lot on nutrition. in terms of prevention. And when I was, working at Temple, in terms of inpatient and dealing with wounds, in terms of the important, the critically ill patients, ICU,
The nutrition is why is it such an important part of wound healing?
Well, you need the energy and protein to heal your wounds.
So it's
And so this is really a problem in, say, nursing home patient who is not able to take in as much calories as they need, and frequently they're tube feeding or whatever. We have a nutritional assessment in our initial visit. We talk with the nursing home to see what we can do to increase their nutritional, whether it be either tube feedings or whether it be neutral supplements, drinks, and so forth. Then we have to be mindful about other conditions. So the nutritional assessment, and sometimes the nutritionist will guide us about how much protein can use, because if they have kidney disease, they can't take so much, or if they're diabetics, we have to watch how much sugar they're given. But you have to maintain the nutritional needs and see how much they do a calorie count, how much they need to do, what they need, because a wound will increase your nutritional needs. Right. So you have to increase their nutritional diet appropriately.
Do you work closely with the diabetic and educations, or because in terms of wound healing as well, controlling your blood sugars is super
all
effective.
The time. We're always looking up hemoglobin A1Cs, which is to see how well controlled the diabetes is, and if they haven't had one recently, we order one.
In terms of blood sugar for being an obstacle to wound healing or to adverse, I was always less than 180, kind of an average blood sugar. Is that still?
I was going to say 200.
Okay.
You got to get it below.
Hey, you guys must be from Temple.
Right? Good training.
No, you got to. Yeah, I mean, you got to be below 200 and not these wild swings. And that's a challenge sometimes. I had a gentleman today, actually, literally today, he's a diabetic, and he's managing his own diabetes. Okay, and so so why don't you go to try and get? We're talking. Oh, I don't have time. It was the landscaper, and so and he's doing it, and so he's 350 some days, and then he's 80, and so he's not. And we're trying to suggest either better control with your primary, or would you want to get an endocrinologist involved? So we're very attuned to the diabetic swings, because the higher and the more erratic the blood sugar, the longer it takes for us to heal the wound.
Yep.
We have a question from Cheryl asking, how do you track your patient progress, and what are your success rates in 2 weeks? No,
well, we do track our progress, and if the wound is not making progress, we check every 4 weeks. Okay. And we have photographs, we have wound sizes we measure every week, and if 4, 6, 8 weeks we're not making progress, especially at 4, we're saying, well, geez, maybe there's something we're missing, or should we change direction and use a different product, or maybe we should see, does the patient have venous disease that we don't see, or arterial disease that we don't see? And so then we start reevaluating and changing our method of attack of this wound. But every 4 weeks we have an evaluation of the wound, its progress, and take it from there.
Great.
Does insurance cover this in terms of, I imagine it does, because my patients don't seem to have a problem going to you, but in terms of, I don't know if maybe this is the wrong person. You want to phone a friend? Is that what we want to do right now?
I think it does.
I think it does,
yes.
Okay. All right, it's fine.
Most of the time, yeah.
All right, good.
And success rates. I know that the Fall River location received kind of an award recently.
We're going to beat them.
So. You're going to beat them. I like this little friendly competition. This is good.
Yes, our wound center at Charlton received a national award for healing rates.
Great.
And I think it was greater than 90%
and I think it was patient satisfaction as well.
And patient satisfaction was 92 or 93%. And so, yeah, our healing rates are as good, if not better, than the national averages.
Wonderful.
I believe, honestly, I've never had a patient whose wound you haven't healed, you know, and also for people who have to go a lot to the centers, I mean, because they go, like you said, once a week or sometimes more, they're all happy, you know what I mean? Like they really fundamentally, you know, are grateful for the service that you guys are providing, and are,
I think
it's remarkable, you know.
We have a great team, and the team is a happy team. And so, like, when you have a lot of people happy in what they're doing, it kind of rubs off on the patient. And the other thing is a lot of these patients have been struggling with a lot of these wounds for a long time. And so when somebody actually takes notice and wants to do something for them, they're like very appreciative, because we're kind of the last resort, if you will. And so when somebody takes notice and interest and starts working on their wound for them, they're so happy. People come back all the time, you know, like or they get healing. Now what am I going to do? You know, where am I going to go? And so it's really gratifying to take care of some of these patients, because they are some of the most appreciative patients.
And like you said, people are shy. I mean, it affects people's ability to wear shorts. In summer, they don't go out. I mean, I have patients, you know, in terms of, or they're just embarrassed about it. So oftentimes I look at people's feet. It's one of the things I learned in my training, honestly, just, okay, how are you? And you're fine. Look at me, just your feet, and you can give a really good idea of actually what they're hiding, is like what their shoes are covering up. So, and like, their socks hurt them, and some of them are painful, and some of them there's odors they're embarrassed about. So fundamentally, just kind of giving them quality of life back is a really good thing. And you see people from, not just like Southcoast doctors, but all the doctors, right? Hawthorne Primary Care, you name it, you know, the New Bedford Community Health Center, you know, accepting patients, you know, from all over.
Everybody. We've seen a number of Hawthorne patients recently in New Bedford Health Center. When I even, you know, Fall River, we see probably a good amount of primary care patients. So it's, we don't pull punches. And
patients can call directly to you guys if they wanted to, in terms of, all right, and the information's
on
our website.
The numbers here.
I don't have the number right in front of me, but maybe we can get that before the end of the show.
The one in Southcoast, I know offhand, because I call it all the time, but the one in New Bedford, I can't remember. It's the Southcoast is 508-973-7447.
Okay.
The one at New Bedford is 508. Mari, give me a hand here.
Josh will find it.
508-973.
5130. Okay. I think I've called it like twice so far. That's good.
Yeah, so for people listening for
you
this,
never know your own number.
508-973-5130 is the new wound center in St. Luke's Hospital. Again, 508-973-5130. It's always on our Southcoast, .org website in terms of finding it. But patients can call themselves. Like they don't, right? You just see, and you can get them in. And how quickly do you get patients in, you know, typically?
Well, at the New Bedford Center, we've been getting them in really quickly. As it fills up, it gets longer and longer. And that's one of the reasons why we opened this center, because the time to see a patient at Charlton has been getting ridiculously long.
I mean, it must be, because in terms of patients are in treatment for a long time, so there must be a rate limiting step in terms of, right?
I mean, it started getting out 3-4 weeks, which is, you know, like sometimes I'd see a patient, the wound was healed by the time they got them. And so, so it's a lot less here.
Good.
And it will get harder, but we are going to open Thursday and Friday up as well, and we'll get up there.
Good.
We're all caught up in the queue. Cheryl did confirm the number for the St. Luke's location, 508-973-5130.
Good.
And then also always on the website, southcoast.org.
Bob, do we miss anything in terms of what you'd like maybe to make sure people are aware of regarding the services that you guys are doing, or
things about wounds you wish everyone knew?
Well, I would just say, if something is, don't wait, okay? Because a lot of these things, if caught, it's sort of like, you know, when I was a colorectal surgeon. If you can catch colon cancer early, then you can prevent a bad outcome. If a wound is there for more than a week or two, and it's still bothering you, or still draining, or still red and inflamed, have somebody check it out. Because those kind of things can end up being a major problem. If I could get people to come in a little earlier, or get even primary care physicians, if they don't have the time, or they don't have the wherewithal to treat somebody, don't hesitate. Pick up the phone, give us a call. We're happy to see them, and we'll take care of them. Okay, and we'll get them healed so that they can get on with their life. But if there's something chronic bothering you, or it's just not healing and draining, that's the kind of thing.
Time is tissue.
Yes, we can take care of it and get it healed for you.
Yeah, and the exception, I think there's a really good point you mentioned earlier. If you are diabetic and you have a wound on your lower extremity,
get somebody to check.
Get some right away. Err on the side of caution and get it checked out. All right, good.
That's great.
And do we miss anything?
No, we're good.
Did we do all right?
Yeah, we did great. All caught up.
Good. Well, thank you very much for taking the time out of your busy schedule on a summer night to talk about the center. We are sincerely grateful for the help that you've provided. I mean, I know I can think of half a dozen patients who have been helped, with wounds that are just grateful. So working together. And we wish you success in the center. I'm sure it's going to be great.
Thank you.
Josh is always our producer. Thank you very much for a great show. Hannah, thank you for all the prep work. And everyone watching tonight and sending questions in, thank you very much. If we recommend you share the show and just kind of pass it along. Unfortunately, the burden of wounds is real and it's out there, and this is a great resource for many of our patients. So please spread the word. The new wound care center at St. Luke's Hospital and the existing one at Charlton and Fall River. We are lucky to have these resources in our community, and we hope everyone's having a great summer. We'll see you next week.
No, we won't. We'll be off.
Oh,
next
actually,
week.
4th of July. That's right.
Yeah.
Thank you, Hannah.
The following week.
Yeah, happy early 4th of July. Stay healthy, Southcoast.
I became a fisherman. I used to scuba dive for cohogs, and that was heavy work. When you're self-employed, you gotta keep going. I kept hurting my back. Then I found out I have degenerative disc disease. I deteriorated to the point that I couldn't stand up. The pain was just so severe. It affected me emotionally, psychologically, and physically. I had probably 12 surgeries, and I wanted to give up. The pain was just so bad. When there's no relief in sight, what else do you have? My general physician, I went to him, I told him I wanted to go to Boston, and he said to me, before you go to Boston, I know a guy at Southcoast Health. So we met with the neurosurgeon at Southcoast Health, and he told me what he was going to do. That's when I started to get happy. The pain had subsided. I wake up happy. I go to bed happy. I can stand up. I saw my surgeon 6 weeks ago. He says, Bruce, you're doing well. And I said to him, you saved my life. And without you, I don't know what I would have done or where I would be today. Yeah, there's a lot of tears, even on his part. I can't tell you how much of a difference it's made in my life. It's totally different. Now, bring it on. Life is good.